Laparoscopy, surgical, orchiectomy. The physician removes one or both testicles, which may be undescended, injured or diseased using a laparoscope. The physician places a trocar at the umbilicus into the abdominal or retroperitoneal space and insufflates the abdominal cavity. The physician places a laparoscope through the umbilical incision and additional trocars are placed into the abdomen. The testis and all its associated structures are pushed up from the scrotum or freed from their undescended intra-abdominal location and removed through the abdominal or retroperitoneal space via the trocar port. Packing may be placed in the empty scrotum. Care is taken to avoid important nerves and vessels in the area. A prosthetic testis may be placed in the scrotum before the incision is closed in layers by suturing. The trocars are removed and the incisions are closed with sutures. Laparoscopy, surgical, orchiectomy for intra-abdominal testis. The physician performs an orchiectomy, the surgical fixation of an undescended testicle into the scrotum, with the assistance of a fiber optic laparoscope. A para-umbilical port is created by placing a trocar at the level of the umbilicus. The abdominal wall is insufflated. The laparoscope is placed through the umbilical port and additional trocars are placed into the abdominal cavity. The physician uses the laparoscope fitted with a fiber optic camera and/or an operating instrument to search the abdominal cavity for the undescended testes. The physician may have several surgical options depending on the mobility of the testis and how far it can be brought down through the inguinal canal and into the scrotum. The procedure may take 2 stages approximately 3 to 12 months apart. Once the spermatic cord is mobilized sufficiently to allow positioning of the testis in the scrotum, which often occurs during the first and perhaps only operative session. A small pouch is created for the testis where the testis is sutured in place to prevent retraction back into the inguinal canal or into the abdominal cavity. The small abdominal incisions are closed by staple or suture in the usual fashion. Laparoscopy, surgical, with ligation of spermatic veins for varicocele. The physician ligates, ties or binds with suture, the spermatic veins and/or excises a varicocele, which is an abnormal dilation of the veins of the spermatic cord in the scrotum. An umbilical port is created by placing a trocar at the level of the umbilicus. The abdominal wall is insufflated. The laparoscope is placed through the umbilical port and additional trocars are placed into the abdominal or pelvic cavity. The physician uses the laparoscope fitted with a fiber optic camera and/or an operating instrument to explore and surgically ligate the spermatic veins to repair or remove the varicocele. The structures of the cord are dissected, the veins identified, and ligated with suture. The abdomen is deflated, the trocars removed, and the incisions are closed with sutures. Laparoscopy, surgical prostatectomy, retropubic radical, including nerve sparing, includes robotic assistance, when performed. The surgeon performs a laparoscopic radial prostatectomy. This cannot be done on a patient with prior open prostate surgery. The patient is positioned for laparoscopic surgery with the legs in low lithotomy position for rectal access. 5 trocars are placed and the cavity is insufflated with gas. The vas deferens is divided, the seminal vesicles are mobilized, and the prostate is dissected off the rectum. The space of Retzius is developed by dividing the urachus medial to the umbilical ligaments. The endopelvic fascia is incised on both sides and the prostatic levator muscle attachments are bluntly removed. A suture is passed between the urethra and dorsal venous complex and tied. A second suture is passed through the anterior prostate. The bladder neck is opened anteriorly, the posterior margin is separated from the prostate, and the underlying seminal vesicles are exposed. The two prostatic pedicles are divided close to the prostate with the involved seminal vesicle retracted. The back surface of the prostate on each side is dissected from the neurovascular bundles until the prostate remains attached only at the apex. Between the two previously placed sutures, the dorsal vein is divided, the urethra is exposed, and the catheter is removed. The urethra is completely divided. The surgeon places a finger in the rectum for guidance and divides the muscles and remaining attachments to free the prostate completely. The vesicourethral anastomosis is done next with polyglycolic acid suture in running or interrupted simple sutures. A Foley catheter is placed and the anastomosis of the bladder to the urethra is tested. A suction drain is placed through a trocar site and the prostate is removed through a small port site incision.